Hey, everybody, and welcome back to another edition of the Open Forum podcast. Today we have with us Dr. David Cartland. David Cartland is a GP, having practiced since 2014 as a GP, and he has been a doctor for the last 14 years as well. David, that's a 2-second, very rough outline as to who you are. Why don't you take 2 minutes, introduce yourself to the audience, and then we're just going to dive on into why we're here today.
Yeah, hi Sonny. Yeah, thanks for having me on the show. Firstly, secondly, yeah, as you mentioned, I've been a GP now since 2014. As well as being a GP, I'm also an A&E GP and an out of hours GP, so I work across a breadth of settings really. In that I'm not just a standard healthcare doctor, as in healthcare centre, should I say. Part of the pandemic, I worked in the Midlands, Birmingham, around those hospitals there, mainly around district generals, and then moved down sort of 18 to 20 months ago to Cornwall to be the sort of next Doc Martin, apparently. It's been an interesting couple of years, really. So I've experienced the pandemic, like I say, in various settings, in various locations in the geography of the UK. And the 2 years experience has been pretty, it's been an observational exercise initially. And ultimately, as I'm sure you're aware, I resigned from the post in the end just because of the inability to escalate my concerns to the people that needed to take action on them, and so that's led to my resignation, and I've quit the NHS since. Long story in summary. And other than that, I'll just say that I'm a family man. I've come down to Cornwall for a good quality of work-life balance. I was living the dream, 3-day weeks, 2.5-day weeks, and learning to surf, etc. And just as an aside from that, prior to being a doctor, I was a scientist. I did a degree in biomedical science and angiogenesis, lots of immunology, virology, and again, I think that slightly sets me aside from other doctors in that the undergraduate program for being a doctor has very little in terms of those aspects of virology and immunology. And, I've seen that play out in the last few weeks where you're trying to speak to colleagues about immunological issues, things like asymptomatic carriage, the fact that the vaccine isn't doing what it should be doing. In fact, it's doing strange things to the immune system, as we've seen play out in the last couple of weeks anyway. And so you can't have those conversations because the knowledge of their undergraduate knowledge isn't very, very good. I'll say it as it is. Compared to that biomedical science degree that I did, it's given me that skill set and knowledge.
It's very interesting that you mentioned that, as that's one of the things that I found as well. So as you're aware, I'm a physiotherapist, but actually prior to that, I've got a biomedical science degree in physiology, human physiology, looking at immunology, looking at virology, looking at drug development and the drug development stages. And I know a ton of doctors. I know a ton of people working in the healthcare profession. And when I have these conversations about drug development and why it takes so long normally and what steps had or hadn't been missed, I was quite baffled to find the pushback was essentially, yeah, but if they say it's okay, it's all right. They can skip that stage where they don't need to do that X part of research. And I'm sitting there scratching my head saying, hold on a minute, I did a whole degree breaking this stuff down and looking into this stuff. Like there's a reason we have it. But
it's a crux of science, Sonny, really. It's a crux of science, isn't it? It's debate, it's discussion, it's hypothesis testing. That's what we're in the business of as scientists. But that transfers across to medicine. I think as medics we're scientists, and that art seems to have gone out of the equation from pretty much from med school, to be honest. The medical degree, we're kind of given guidelines. Is kind of the teaching was almost sort of
follow the manual.
Follow the manual, exactly, and you don't get to think outside of the box. And if you do, you're made to kind of just doubt yourself. Really, it's all sort of guideline, algorithmic led. And as you mentioned, from both of our science backgrounds, I mean, even things like medical statistics, I'd say, discussing confidence intervals and significance, it flies over the head of most senior GP colleagues. That's the bread and butter of reading a paper, appraising it, and coming to conclusions or not, and having that debate. I'm more than happy to be wrong on all of this stuff that I present to my colleagues, and I really wish I am and hope I am, but I don't think I am.
You and me both. But let's come back to, well, I'm sure we're going to touch on that later on in the conversation, but let's come back to the reason that you stepped away after 14 years working as a doctor. After the last 8 years of working as a GP, you decided about a month ago, give or take, that, you know, enough's enough. You need to walk away from that particular situation and send your message that way, that if you guys aren't going to, you know, make a change or make a difference in what we're seeing here and what we've agreed that we're all seeing here, I need to make some kind of louder statement. And if doing it within the meeting isn't enough, I need to do it by handing in a letter of resignation. Can you maybe talk to us about the steps that led to that, what it was that you were seeing, what it was that unnerved you at that point in time?
Yeah, it's a big question, Sonny, to be honest. It's a wide question, but I mean, over the last, I mean, my whole GP career, really, without sort of playing the violin, it's not been a great time to be a GP, really, in terms of just generally the amount of that's expected of you on a daily basis and inability to do your job properly, you know. And we've seen that in the back end of the pandemic, really. The patients have been presenting later and later with things, you know, things like massive weight loss, rectal bleeding, etc., and you just, you know, you've got angry patients from the outset because they haven't been able to get to you. You can't give them the service that you want to give them. That's sort of outside of the pandemic, really. That's the sort of setting off. It just not being a very fun job anymore. And then just the 2 years really was the sort of, I keep calling it the sort of Titanic after the iceberg, really. That it feels like, you know, it's that very last few scenes from the Titanic now of the sort of ship pointing upwards and on its way down. And it's, I mean, there's a few things really. It's not something I can answer really easily and quickly. It's things like, you know, the mandating of vaccinations for NHS staff. That was a real, just, and bearing in mind, just to set the context on these, that I am vaccinated. That's the interesting thing that sets me apart. I've had 2 vaccines for very different reasons. So I'm not an anti-vaxxer. I support vaccinations, you know, in all other settings. That's the one thing. But yeah, the mandate was a big one. I just couldn't get my head around how, you know, they were willing to, you know, sack people. I mean, people have been called out and they're treated very differently for being unvaccinated, and it just doesn't go along with the ethical code that I signed up to. That's one thing. Obviously, that's in this country that's been sort of pushed down the timeline a little bit, and it's all because it wasn't because of, you know, the autonomy of the nurse and doctor's body and their personal valid refusal of consent. It was because they couldn't afford to lose the amount of staff that they would have done.
It was projected.
It was projected, you know, and so that was that. So I mean, that was a big kick in the teeth, and you know, I was never going to be sacked. I'd had 2 jabs, so I was all right in terms of the mandate. Second thing really was around just seeing things that were, you know, a couple of things really, that the vaccine wasn't working. Vaccine wasn't working in that, you know, the vaccine is supposed to do a few things, you know, and it's certainly not doing any of them in any way, shape, or form. What I mean by that, Sonny, is that, you know, when you take a vaccine treatment, you want it to stop you catching and spreading the disease. Correct me if I'm wrong. And the second thing is you want it to stop you from becoming poorly and die. But the statistics that I was seeing coming out of multiple governments, and you can see that in the UK data, the Scottish data is very good for demonstrating the percentages and things. The Israeli data, well, worldwide data supports it, that it doesn't stop you catching, it doesn't stop you spreading. We've seen in the recent weeks that, you know, it's a disease of the vaccinated, really, these COVID positives. And I did a very small study at my own surgery that showed that was the case in high percentage terms. 95, 96% of positive tests were treble vaccinated in a small cohort. That's been replicated. So it doesn't do that. It doesn't stop you from becoming poorly and going on into hospital. You know, we're talking about sort of 4-to-1 ratio, the 4 being treble vaccinated people in these country studies, the UK and the Scottish data. And then the final harm is obviously death, and 4-to-1 ratio, and it's got even worse actually. It's almost 90% now in the Scottish data. And 90% of deaths are in the treble vaccinated, which is, so it's not doing any of the things. And finally, it's not safe. I'm seeing lots and lots and lots of signals of harm, as I call them, you know, people just coming in not right, people that are, you know, you've seen the myocarditis in kids sing, I'm sure. But, you know, everything from weird and wonderful autoimmune things being kicking off in people's bodies, strange fatigue, memory issues, neurological, dermatological, reproductive, cancer, everything. I've seen it all, from death to just not feeling well, and everything in between, as I've been saying. So, and you can't call it out. You're saying to your colleagues, you know, there's no real willingness to attribute these things to the jab. You know, people will drop down dead days after their jab, yet no one will even want to talk about the potential. You know, we're seeing that. You know, many colleagues contact me and saying, you know, they saw a 16-year-old, for example. I got this yesterday with myocarditis in the local hospital. He had the jab the day before. You know, myocarditis is so obsolete in that age group; it doesn't happen. And we're seeing it. You know, we see it on our TV screens for the footballers, the military data coming out of the Department of Defence. It's an epidemic of harm. And it's, you know, we've got to put it in context only of what Omicron is now. Omicron is endemic. It's getting to that point now where, you know, we've either had it, going to get it, it's self-limiting, you know, general viral advice. No one's in ITU with it anymore to a large degree. You know, there's outliers, obviously. You know, we saw at the beginning of the pandemic, people were poorly. Were they poorly of a virus, a novel virus? Possibly. A lot of the people that were really poorly were because of their immune systems kind of overreacting to this new pathogen, and it was cytokine storm, hypercoagulable, kind of blood clots flying everywhere. And so just seeing all of this harm and just not being able to, sorry, it's a long-winded answer, so I need to go this, but it's all of these things together that contributed to the fact I can't work amongst people that are not willing to recognise harm, have a scientific debate about it. But ultimately, you know, we've lost our values as doctors. You know, we're very busy all the time, and that's everyone's excuse. We're busy, but we've lost our basic ethics and morals around things like consent, confidentiality. You know, no one's being consented for these jabs. You know, they're not valid. It's not valid consent, put it that way. And things like, you know, I've talked about in other interviews, the Hippocratic Oath, do no harm, you know, good medical practice guidance that we have in the country is very specific, over 12 domains, about things like make your patients your first, you're the advocate for the patient, make them your first concern, do no harm, etc., etc. And people are seeming to forget that. You know, people, my colleagues now as we speak, have probably sat there with the plan to help people today. Help people in their, you know, mental health, their physical health, their social circumstances. But that's fine. But when it comes to COVID, they seem to forget that. It seems to be a sort of law unto itself.
Yeah, all out the window just for this one thing.
Mm-hmm.
There's a few things that I want to unpack there. There's one element of the vaccination adverse events that you just mentioned, but I think one of the important things right off the bat is that you mentioned the statistics 4-1 in terms of triple vaccinated getting COVID, in terms of the amounts of death and whatnot. And a lot of that's coming out of the Scottish data, which, funnily enough, as of, I think, Friday last week, they've now announced that ONS is no longer going to publish the Scottish data because people are using it in the wrong way. But data is data. But someone listening to this might say, yeah, but the thing is, Dr. Cartland, there are a lot more people double jabbed and there are a lot more people that are triple jabbed than there are unvaccinated. So it's always going to look like more people, right? Or is there something?
I get that, but on most of these graphs on the left-hand side of it, it's looking at the ratios of who's treble jabbed. So it's treble jab versus all others. So it encompasses second 2, 1, and 0 jabs in that second bar. So, you know, proportionally, those proportions are less than, for example, I think the Scottish data, something like 72, 73% are treble jabbed. But the percentages of death are, 87 or 88 at the last look before they sort of hid the data away for us misusing it. And the second thing is, you know, why would somebody die of COVID once they've been treble jabbed? That's the purpose of it, yeah. That, you know, you're supposed to prevent you from dying from the disease. You know, it's a sick irony that you would die in a sort of ratio of 4-1 treble jab versus all others of COVID when you've been vaccinated for COVID. That's the way I read the statistics. I get what you're saying about proportions, but, you know, they are percentages. It's easy to sort of understand, and I get what you're saying in terms of.
Yeah, no, but it's good to get that clear for people listening as well. These are corrected for the numbers as well, for the proportions of unjabbed to single to double to triple.
In other data sets, so you see that in sort of it puts it as ratios per 100,000 as well, so it standardizes that data, so you can, and it's still the same end result. You know, it's a disease of the treble jabbed end of.
Then another thing that you mentioned is these injuries that are occurring with the vaccine. Now, only up until the pandemic was never familiar, and I'm not a doctor, with the yellow card scheme. And one of the things that you hear is not a lot of doctors are as familiar with the yellow card scheme either, or medical professionals. So if they're seeing adverse events, regardless of whether or not they're attributing it to the vaccine or not, there are going to be people that aren't well equipped to report that data, right?
There's two parts to that then, really. It's the fact that, that just logical discussion around that chap that collapsed clutching his chest yesterday, the day after his AstraZeneca jab, has got anything to do with it. So the doctor has to attribute that in his own mind. And that's one barrier that's not being overcome by doctors. It literally is the temporal relationship to the jab itself and the event, whether it's a stroke or a PE or a heart attack or a myocarditis episode. So then they've got to have the time to report it, and they've got to know how to report it. So, it's a busy job. If you get your sandwich break, you're lucky. So these yellow cards are pretty labour intensive. You go, and we're expecting members of the public to do this when doctors, look at the screen, and things like DATIX reports for significant events in hospital, for example. They're not very user friendly. Funny that, but you get 4 or 5 pages into it, and I can't comment for other doctors, but I'd like to say I've reported every single adverse effect that I've seen, but you just don't get time. You'd be working till midnight if you did. So, the data is very much underreported. Yellow card have got adverse reactions recently. I think it's 1.4, 1.5 million. They're certainly not the adverse events that you read in, like you see when they're talking about the children's vaccinations. There's a guy from the JCVI talking about the side effects of it, and he was talking about muscle aches and headaches and general malaise, a bit of a temperature after. But he never mentioned the actual, the very real risk of things like myocarditis. They call it very rare, but then they don't quote the data, which is bizarre. They don't quote, this is what's been going on throughout this pandemic, that the standards I have to work to as a sort of anti-vaxxer, if you like, I have to back everything I say up with data and statistics and peer-reviewed journals. But at the same point on the radio, you can flick on a channel and it's telling you that you've got an 8 times less chance of dying of COVID if you have your booster as a pregnant mom. Take your booster, it produces you. Where's the data? There's not even a reference to the data. You can hear Sajid Javid speaking in Parliament. That speech about the medics and the vaccination mandate, you didn't back it with any data. The people that do come back with some rebuttals on my data sets that I present, they're not giving me data back. They're just saying, well, they aren't giving me back, and then their rebuttal is just a name call or a block. And I've seen that in my own surgeries, that they just will not enter the debate. I keep saying that it's really, really easy to get these people shut down. So if you've got these raving lunatic mobs outside the vaccine centre calling out for safety data with the children, if they've got that data, then give it to them. They'd be off quicker. Problem solved, yeah. And they know, and you can see it in their faces that they know. And that's what keeps me calm in all of this, is that, this is only a matter of time. The data is so beyond all reasonable doubt. It's coming left, right, and centre, whether it's myocarditis or blood clots in adults, or we talked before we started the interview, didn't we, about pregnancy issues. We're seeing this link between unprecedented numbers of fetal
issues. What is the data then? Because you and I are saying the data shows, but what is it that the data is showing? Have you got any sort of?
So there was the study that I'm thinking of in terms of that was an Israeli study, and it was about, I think there was a big push for the vaccination program back in February. Get you, similar to what I've just mentioned, get your jab in pregnancy, it's safe. Again, no data references. Even just give us figures about how many pregnant women have become poorly from Omicron. This data is impossible to get. It's impossible to get. But yeah, it just showed essentially it was from that month of pushing the vaccine to 6 or 8 months into the future, just an increase in all outcomes really for, fetal malformations, early miscarriage, late miscarriage, stillbirth, and the ratio between the vaccinated group and the unvaccinated group flipped very quickly towards, lots of these awful things were happening in the vaccinated. See something that happens in a normal distribution, which is like a bell-shaped curve, then that's pretty solid. That's a good representation of a cause and effect, if you see what I mean.
Yeah, absolutely. And then another thing is, I find the term anti-vaxxer it's a bit of a pejorative term. It's one thrown at people to immediately shut down the discussion. Like you mentioned, they want to go for
called worse, believe me.
they want to go for name calling rather than bringing the data to you and then discussing in an open, honest way of this is what the data is actually showing. So, hey, the vaccine is or isn't safe. And by no means am I trying to tell people what to or what not to do. And I don't think that that's your intention either. I think you want people to have an open debate, which is the scientific method to look at something. If we have this hypothesis of there might be an issue, we need to then test it, or at least look at the available data to then see what way things are leaning, what signals we're achieving from the data. Now, pushing forward, you mentioned also the child statistics. Is there anything there that we can look at and we can unwrap as to say, look, we have a very strong signal here that there's something going on?
Yeah, I mean, I use the myocarditis data because it's so robust and so clear. And you know, if you talk about children that are becoming harmed by the vaccine, and you're talking about harm that is literally, I say, heartbroken. You know, the children with broken hearts because their hearts are becoming inflamed. So a couple of the studies, really. I mean, there's one in pretty much the gold standard, really, for looking at a cohort study was the Hong Kong study, and it was pretty much they'd followed a cohort of people after the jabs. And found that I think it was 2,750 or 2,800, one in 2,800 children. So this rare side effect of one in 2,800 is not as rare as you would imagine, is it? That's not, if you imagine a football stadium, for example, that's quite a few people at the new camp that are going to be suffering from a myocarditis after the jab. You know, these are real numbers, and you know, for the benefit, I mean, you've got to look at the means justified by the ends, as it were. And the disease itself, I mean, I haven't even, you know, I don't think in the 2 years I've spoke to anyone in the bracket of under 20 that's been, you know, admitted or poorly enough to go to ITU. Under 20s. It's a disease made of the elderly, of the comorbid, of the obese, and we've seen that across the studies. That you know, the average age of death from COVID is 2 years above the average lifespan of a male, for starters, which is an alarming thing. So it's essentially a disease, and you can't really translate that across to the 13-year-old fit, healthy teenager. They're by no means comparable in any way. So
I think one thing to point out there is that of the data that is available of people in that age bracket, under 20s, under 15s, that have unfortunately passed. Every life that's lost is an unfortunate event. They are also people who have these comorbidities that are seriously ill. Some of the statistics, I think, some of the statistics you see, cancer patients that are already almost at end of life, and this just happened to be the thing that knocked them off.
Well, if you think about the statistic really in itself, the deaths that we're being sort of given, you know, that yellow ticker tape is within 28 days of a positive test, you know, and I've seen it myself where I've sent people in with, you know, definitely not COVID, strokes, you know, heart problems, and they die, they succumb to their illness, and at some point along the chain they've had a positive test, and they get added to the figures. And you know, this is what I'm saying about the discrepancy between the underreporting of adverse effects in the adult population through the yellow card system, and then the massive overreporting. You know, I won't sort of look at you know, there's some degrees of overreporting here that pull those figures very close. You know, if we're overreporting deaths and underreporting adverse effects, you know, there's 2,000 without, you know, any debate, 2,000 deaths on the yellow card system as per now, you know, and if that's underreported by a certain percentage, you know, we're getting that figure closer and closer to the deaths with 1A COVID, and I mean just 1A as in that's the only cause of death on the death certificate, which is, I think, is a more reasonable statistic than get struck by lightning. 28 days where you had a positive swab PCR, and then death certificate reads COVID-19 not struck by a bolt of lightning.
Yeah.
For example.
This fudging of the data, shall we say, with regards to people dying from whatever cause it might be within a time frame of 28 days post COVID test. Actually, initially, it was of any point in time they've had a positive COVID test, and then the NHS, I think the NHS then said, right, we're going to do it only from within 28 days. So at the very beginning of the pandemic, we had a lot of these potential hypotheticals of a lightning bolt, let's say, and if they tested at any point positive for COVID prior to that, whether it was 28 days or longer, they're going to unfortunately go down as a COVID death. So there's also that bit of data that came out from the Freedom of Information request of about 17,000 people that COVID was the only cause of death on their certificate.
People debate with me that freedom of information that you mentioned, that 17,500 as opposed to 180,000. You know, that's a big difference there. You know, I prefer that piece of data as, you know, as reliable as we can be. Me seeing a 1A death certificate that says COVID-19 is a lot more reliable than run over by a tractor in Cornwall 22 days ago. They had a positive swab. Death by COVID, it's just nonsense. But they're still using that now, and that's what you see on the ticker tape, that death toll. It's so vague and nebulous, and it's such an important statistic. Why is it so difficult to just say these are the actual amounts of people that died of COVID? It's not that hard. Like I can say, you know, that person had a heart attack, you know, and this many people had a heart attack this year, because it's very easy to do.
if they can keep that ticker tape data so up to date, I'm sure they have a way to collect it to actually.
It's really difficult to find. I use this in my local hospital. So we had a Freedom of Information Act at Treliske Hospital, the local Cornwall. It serves the whole peninsula pretty much. And there were, I think the figure was 10 deaths with 1A COVID in the whole pandemic, or over about a 14-month period, 10. And people are shocked when they hear that. And just, you know, the next thing would be, how much did Treliske add to that 180,000? Can't find it anywhere. There's pages and pages and pages of daily data sets, but there's no cumulative. I spent hours and hours trying to find out how many did they add, how many total deaths from COVID did you add to the list, Treliske, and you can't find it.
No one has that data. That's also very interesting to hear, that, you know, we can tell you how many died from COVID, but we can't tell you how many we added to the overall number.
Equally, I mean, not just deaths, but the adverse reactions. We talked about underreporting and people not knowing how to do it. But ultimately, you know, locally, I've talked about local levels. Like I've seen, for example, lots more blood clots recently, you know, and I'm just correlating that with, you know, are we keeping an audit here at the surgery? Are we keeping a local audit, a register of new PEs, for example, or strange cancers that are coming through, or infertility stuff? And these are the things that I've noticed through the time, you know, having to send more cancer referrals than ever before, fertility referrals like never before, you know, and no one's keeping that information, considering it's all part of a, you know, a trial. I will say it is a trial.
Up until next year, yeah.
Up until next year, exactly, yeah. And I mean, the children's trial.
The fact that, that's the other thing, right? The JCVI said no to it, and yet we're still going forward in the UK.
It's bizarre, isn't it, how they've turned, haven't they? They've gone from advising not to, and then everyone had the first jab. And I think it was handed over at the time to the sort of general medical officer to take that decision, and they overruled what the JCVI. I mean, if the government aren't going to listen to the JCVI, that's their business. Yeah. What's the point? And then lo and behold, you know, they're going for the second one now in the 12 to 17 categories, and then each day becomes a worse nightmare. They go for the 5 to 11-year-olds next, who are not at any form of risk, other than massively comorbid children. You know, like I say, you know, sick kids are dying sadly, but they happen to have a COVID positive, and then, you know, they get added to the figures. You know, I don't think the figures are very high. I think the ONS data shows it at something like 10 deaths under 20, 10 deaths in the whole pandemic in the UK. 10 deaths. So that's not good public health policy to vaccinate every under 20-year-old healthy with any potential risk, even if it's 1 in a million. No, they're not 1 in a million, as I mentioned from the Hong Kong study. They're not. You know.
This is the other thing, right? There's no conversation about your NNT, about your number needed to treat. There's no conversation about what the data actually showed in terms of absolute and relative risk and benefits from the injection. And I think, you know, if we start talking in terms of NNTs, a lot of people are going to turn away from taking their kids for the injection.
Yeah. I mean, that's the only thing now. I mean, the difficulty in all of that is you're blinding the doctors with science. I mean, the poor member of the public seeing all these graphs, you know, next slide, please, next slide, please. You know, they're listening to that as gospel. You know, what Chris Whitty says, Van Tam says, you know, they've got the public in the palm of their hands, so whatever they say goes. But they're blinded by all this, because these guys can't understand these graphs that are being sort of flicked through when they're doing their daily updates. You know, and as you mentioned, NNTs, probably, you know, I wouldn't give percentages, but not many doctors even know that sort of statistical knowledge. And that my own knowledge of that came from my first degree. You know, I didn't touch on medical statistics in medicine at all, other than significance and confidence intervals, I guess.
Yeah, same as myself. That's where I know about NNTs. That's where I learned about relative and absolute risk and benefit and whatnot. But before we take it a step further, one of the things that you mentioned is the really easy data to see in terms of myocarditis in children. Now, what we're hearing from the government, what we're hearing on the news is that they're mild cases of myocarditis. Is that such a thing? Is that really something that they can?
Well, even as you say that back, you know, just a little bit of inflammation of the heart muscle, you know, is that okay? You know, for
Right.
very little benefit in terms of, you know, it's, you know, once it gets to moderate and severe, you're talking about permanent heart damage. You know, these are kids with, as I mentioned, broken hearts. You know, their hearts are, it's like the brain tissue. Once you've had a stroke, the brain tissue isn't the same again. Same like after a heart attack, you get heart muscle damage, and it's not the same, you know, sort of muscle as it was prior. You know, the pump function is limited, and again, we don't know, you know, how badly that's going to affect them. But you know, we're seeing these kids dropping down on the football pitches. We're seeing the young fit sportsmen dropping down in their droves. You know, football stadiums, people collapsing in the crowd. You know, the proof of the pudding is in the eating, as they say, isn't it? If you're seeing this left, right, and centre, you know, I'm a big football fan. You know, said in a previous interview, you can remember by name the people that have collapsed on the football pitch and had a cardiac arrest. It's happening on every single weekend now, whether somebody in the crowd.
Someone new, yeah.
There's a young golfer, 17-year-old, dropped down dead on the golf course the other day, martial artist. You know, people in their prime physical condition, dropping down or dying in their sleep. Death certificate reads natural causes. It's not natural cause to die 2 days after a jab, for example, in your sleep as a 16-year-old. That's nothing natural about that.
It baffles the mind that it's just being pushed off to the side as, like you say, natural causes, or yeah, these things can happen. I saw a doctor who works within FIFA saying, oh yeah, but we have these things happen all the time. We're just seeing it more so now. I've only been traveling around the sun for 30 years now. You've been on the planet a little longer than myself. How many do you really actually remember seeing? Like you say, you can name the amount of times that people have dropped on a field or in the crowd. And that's the even crazier one, because the guys on the field, if they've got myocarditis, if they've got an inflamed heart, they're going to have issues when the heart's beating at maximum pump, right? That's, you know, okay, if it's going to happen to the footballers, it's going to happen on the field, or if they're having a hard training session. But for it to be happening to people standing in the crowd.
I mean, I think so. There was a case of Sunderland. I think their manager, I forgot his name. I think he's been sacked recently, but funny that. But he couldn't put a team out because all his players, he couldn't find a goalkeeper because all his players were suffering from heart conditions, or, you know, they were being vague about it. But I think he had 4 or 5 players from his first team that couldn't play. You know, you've seen Sergio Aguero. You know,
he's had to retire. Yeah.
You know, there's big, I mean, these are only the big cases because people see them, the Christian Eriksens, for example. You know, we can but speculate it may be something completely unrelated, but, you know, I think the public have a right to know, you know, if it's a triple jab footballer that's gone down 2 days after their whatever branded jab they had, because, you know, this is all just data sharing, isn't it? But you can't mention it. I mean, they're very dubious when they report on it. You know, people saying, was he jabbed? Was Christian Eriksen jabbed, for example? And, oh, we can't answer that, you know, very grey. You know, just answer it. You know, people have got a right to know, you know, if their favourite footballers dropped down after a jab.
You get the impression that if he was unjabbed, they'd put that out there, because this is what they did with the Olympic coach, right? They called the guy an anti-vaxxer. He died, and they said anti-vax coach dead, 6-time Olympic medalist or whatever it was. And then actually in the fine print of the article, they say, oh yeah, he did recently just have a jab, but he was an anti-vaxxer.
It's bizarre, isn't it? This illusion that's being created, and people keep saying, why? Who's behind all this? What's the end game? I don't know the answer to that. Why would we be doing this? Like deception? You know, I quoted in a previous interview somebody going around the ITU saying, you know, ventilated, unvaccinated, COVID positive, and, you know, sweeping around the department. Not one of them was actually ventilated because they were COVID-related illness. There were other things such as, you know, stroke patient that had all those 3 criteria. They were ventilated, COVID positive, you know, and You know,
It's
they
just
were,
circumstantial.
unvaccinated, but you know, there's a lot of this, and that's a well-known fact that doesn't get talked about. You know, this kind of incidental pickup rate. You know, it's people go in with a broken leg, COVID positive, and they're on the COVID ward with a fractured neck of femur, for example. It's just manipulation, illusion, delusion, deception. I don't know what's going on, but I can't be part of it anymore.
No, and this was something that I wanted to touch on too, as well as, like you say, you worked as a GP within the A&E, you're within the hospitals, you're in clinic. I spoke to a CCU nurse from Canada, and she was saying her lived experience in the hospital was completely different to what she was witnessing on the news of the hospitals, XYZ overwhelmed. And that's not to say that they weren't at points. They were. Absolutely, they were. And she was very adamant and clear, like, look, we did have times where things were really dire. But then the messaging coming out from the news was that it was constant and consistent and never ending. It was wave after wave, storm after storm of patients coming through. Now, she then said, actually, we had those moments, but then we had moments where our ICUs were filled up, or CCU was filled up with either spousal abuse of patients, or attempted suicide patients, and things like this. And there are these other things that are affecting everything that's going on. But the messaging was still consistent on COVID, 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 ticker tape, COVID, 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 ticker tape.
I mean, the media are always elated to report for some reason about that unvaccinated guy, as you just mentioned, that died of, just as an example, really, that the unvaccinated guy, and actually when you read the small print, he wasn't actually unvaccinated, for example.
Yeah.
It's almost like, let's rejoice. There you go. This is what happens when you're unvaccinated. Your conspiracy theorists, this guy answered with his life. Almost like, no. But
yeah,
it's bizarre. It's an odd mentality that this, and I don't know what's behind it. I wish I did. But the statistics are coming out, and they're just very consistent with what
you've seen. Yeah.
And you know, that you mentioned that CCU nurse, I'm inundated since I've left, that people, you know, whether it's on Twitter or Facebook or phone calls out of the blue, just lots and lots of collaborative evidence of, you know, people's experiences and observations, and, you know, people actually quitting. That's the next problem we're going to have as an NHS now. People
Lots
have
of
had
personnel. Yeah.
Lots of personnel. People have given up. Really good nurses, I know, A&E doctors, they've had enough. You know, like you say, you've had that experiential, very different experience to what you're seeing on the BBC of the evening, where they're all wandering around in hazmat suits. You know, many nurses I know that worked on the COVID wards had quiet times, very quiet times. Sometimes the nursing staff outstripped the patients by 2 to 1, 3 to 1. You know, there is a very relaxed time, people say. Considering it's a pandemic, I've not seen the people, you know, on my own lists as a primary care doctor, is sort of screening 50 patients a day, for example. You know, you'd expect a good chunk of them. You know, if there's a bubonic plague in the rounds, you'd get people with hemoptysis, which is coughing up blood, you know, chest pains, breathless, and not in the numbers that you'd kind of BBC would have you believe.
No.
You know, you hope that the sickies would really go to an ITU or an A&E setting, but we know that doesn't always work out.
No. And the thing is, sometimes they're turned away until they're too sick. And then by the time they're admitted into hospital, they're already on their last legs.
Yeah, I mean, there was a girl who recently just, she had quinsy. She rang me up from my hometown that I lived in, and she said she went into the A&E via an ambulance. She had high fever, delirious, couldn't swallow her saliva. And the whole waiting room knew that she was unvaccinated. They wouldn't admit her to the hospital because she wouldn't take a test to start with, and she was unvaccinated. So they were talking about admitting her to the COVID ward because she was refusing the test. In the end, she self-discharged, had to go to another hospital, and she's been on an IV drip since. She's just gotten over it. And, you know, this is what I'm saying. Are these nurses not consulting their ethics? They're doing the job because they want to help people, yet calling out people that are unvaccinated, you know, segregating them, you know, medical apartheid. You know, there's talk about unvaccinated nurses and doctors having to wear a little badge just so patients knew that. Now, when I do CPR on somebody, I don't question their, you know, any status really. You just get on and do it, don't you? You know, you just get on and do it. Now, it's just absurd.
It's what you signed up for.
Like, no, I don't stop treating an alcoholic because he's an alcoholic, or a smoking COPD patient that keeps needing antibiotics. You know, mine is to treat them and reach a therapeutic alliance with the patient, not to judge them. But we're seeing that judgment with all things COVID.
We'll come back to the messaging in a minute, But there's something very important that you touched on, this aspect of, we don't refuse to treat the obese person who just has this incessant need to eat. We don't stop treating the COPD patient who has got on there because they've been smoking for 60 years of their life. We don't stop treating people who have neurological conditions due to alcohol abuse over the course of their life. We don't say, you did this yourself, so good luck, son. Off you go.
I mean, you see horror stories now in America, and I don't know if it's come across the Atlantic yet, but people being kicked off the transplant list for livers and kidneys because they weren't vaccinated. There's absolutely no science behind that whatsoever. It's like a discrimination, isn't it, for not wanting a vaccine?
And it's being championed. It's being championed by people who work in healthcare to an extent. I've heard doctors telling me, yeah, all right, yeah, you're right. We should still treat them, but then they should pay for their treatment because they decided not to get jabbed.
When did we ever start practicing that sort of ethical approach to patients? We've never done that. That's what I've seen really. The biggest issue for me around all these things is that suddenly the doctors have lost their sort of ethical focus. Discriminating. We did. When did a valid refusal of consent not be a valid refusal of consent? If somebody stated, conversation even a few weeks ago, a patient was, they just had enough of life. They stopped eating and drinking, for example, and they had full capacity. They just didn't want to go to hospital. The family were there. We were trying to get him to sort of see around it, but it was absolutely his right that day to not go to hospital because he'd fully weighed up the benefits and risks. He didn't want to go into the Treliske Hospital. And that's within his right. It was a really difficult conversation, but that's something I can't, to throw him into the back of an ambulance is battery and assault, and that's always been the case. I don't pinch patients' noses and make them swallow the antibiotic. I tell them the pros, I tell them the cons, and that's really important. And we touched on valid consent earlier that, not only is a valid refusal of consent valid, but, the consent that was sought in the first place wasn't valid consent. You've got to be given the cons. I've talked about things like, even if it's small print, even if it's really small print, chances of, for example, death by general anaesthetic or, bleeding out on the table for your appendectomy, you still need to know about it and sign your life away when it comes to the consent form. But I certainly didn't witness that sort of consent in the conveyor belt that was the vaccination centre, where they're going through hundreds of people in one afternoon, just like a pneumatic jabbing machine. And it's just bizarre that it's a cursory few questions. There was hardly any medical screening. Patients didn't know what they've got. I mean, even now I speak to triple jab patients that don't know what they have jabbed into them. You mentioned mRNA, complete blanket rules, clinical trial. You sound like a lunatic if you mention it's part of the clinical trial. Why would it be part of a clinical trial? Have you heard of a yellow card? No? What's a yellow card? It's bizarre. I mean, that's part of the valid consent. If you have a reaction to this jab, this is how you process that reaction, in terms of reporting it. Yellow card, green book, let your GP know. None of that was said, or very rarely was it said, let's say.
Yeah. So how much of that have you seen then in clinic of these?
Well, I took a sort of conscientious objection to taking these, to giving any jabs, so I've never given a jab. So often it would be just me ploughing away through the patients of an afternoon duty doctor list, and all eyes were on the COVID clinic. The whole building was taken over. So I've heard earshots of, I've spoken to people, that have had the jab, and, asking them, what did you understand? I mean, I keep being offered the third jab, to be honest. I keep getting these texts and emails, and I'm quite tempted to go down and at least be counselled about the effects. The effects, to see if they know their stuff. As an injector and a vaccinator, you need to know your stuff because you're injecting the drug into somebody. So if you don't know the statistics about the harms and the benefits, then you've not got a right to be a vaccinator. And these vaccinators are everyone from the pharmacist to the very most junior members of the nurse practitioner team, nursing team, receptionists. You get to do a three-hour computer course. You're fully good to go. Even the students have been vaccinated. They've come for an education, yet they're on the conveyor belt too.
Yeah, I know a couple of people that signed up to do it here in the Netherlands, and when I speak to them about the statistics, they're like, no, that's not what we were shown, so that can't be true. I'm like, this is legit data. You can find it on PubMed for all I care. I'll give you the PubMed ID. And then I don't know, the data we saw it's very robust. Had a conversation with them as well while my other half was pregnant. about her not wanting to get the vaccine because she's pregnant. No, it's completely safe. They've done the studies. This would have been
Asked to see the study, Sonny. Asked to see the study.
I didn't get one.
Conspicuous in its absence. Yeah, exactly. I mean, I end up on these sort of social media debates, and if you get engaged, you've done really well. But then they sort of throw a little bit of data from a sort of a letter to the BMJ, for example, so it's not even peer reviewed, and so you go back with a rebuttal, and then they disappear. So you just there's only so many times, and then they just disappear, or block you, or call you a name, or and that's wonderful, isn't it, when it comes to debating science and observations and things.
Oh yeah, didn't you know the best way to win a debate is just to block and name call? It works.
As I said before, I'll happily be wrong on all of this, but I'm asking for just simple data, just to give me. So I'm fully aware that I'm seeing one side of the coin. I'm part of the groups that are just we're bathing and drowning in all this data that shows the negative side of vaccines not working or harm from vaccines. But I'm not seeing anything from the other side of the scientific community, what the 99% of people on the other side of the equation that are just full faith in the God-given gift of the vaccine. Give me the data. I'm happy to be wrong. I'd love to be wrong, but I'm not.
So with that said, then, you didn't do any of the vaccinations yourself, but did you have to do any reporting for patients after the fact, without speaking about any specific patient data?
Yeah, I mean, both patient and doctor can report it. So as I mentioned, it's a busy old life being a GP, but I've done a few, but not, I know I've underreported, but I know a lot of people haven't reported or also underreported what they see, so you strongly encourage. I saw somebody the other week that had again, I've got to be careful what I say about confidentiality, the entire arm and leg had swollen up after the vaccine, massive golf ball lymph nodes all over them. And to get an answer from a fellow colleague that this was any way related to the jab, despite it happening 2 days after, was impossible. And I asked her, I said, did you do the yellow card? What's a yellow card? Explain that. I said, showed her the website. I've asked her to do it, really, because you can't, there's so many coming through, you won't be able to.
Can't do them all.
Can't do them all. Yeah.
It's funny that you mentioned that, as I've seen patients coming into my clinic in physiotherapy with those exact complaints, and then I say to them, like, listen, did you speak to your doctor about this, or make an appointment to speak to your doctor about this? People with heart palpitations and stuff. And they're like, yeah, I did. My doctor said it's impossible because it's safe and effective. And
there's no association of causality at all. Again, loads and loads of those. Actually, interesting you mentioned about sort of funny arrhythmias. So, not only heart attacks and myocarditis, but people having the jab, and some matter of hours, literally hours after, going into SVTs, fast AFs, all these tachycardias, and just feeling unwell, and just regretting the decision that they took the vaccine. And I think a lot of people are, or will soon, regret the fact that they took all three.
I have had a fair few people messaging me after the fact, because see what I post and whatnot, saying that they've had XYZ effect following. But further to that, then, are there any colleagues that you're working with that have acknowledged that there's potential, or are there any medical colleagues that are open to the idea?
I'd like to say that there are, but not that I'm aware of in my locality, let's say. There's a lot nationally, and we're connecting as we speak. We're part of things like the Heart Group I'm part of, and other sort of across the countries, little groups, little pockets, but not as little as you would think they are. And there's lots of people, and we keep saying we're awake, or words to that effect. But I think everyone else needs to be awake. Actually, it's a bizarre phenomenon. Yeah, to answer your question, no, there's no one locally. I've lost good friends over this, medical colleagues. Good friends, they just block me. And all I've said is, can you watch this video? I've presented pediatric harm data to a child safeguarding doctor, for example, and they just walk out. You're disturbing my coffee break. Bizarre. And this is, I can't tell you I've got one ally in the whole Cornwall. Not one, medically speaking. And these are sensible people. These are people that I've worked with for years and years, and they're friends as well as colleagues. So, bad people, in fact, quite the converse. I've had people agree with me. For example, there's no benefit around vaccinating healthy under 20. But I was absolutely agreed, Dr. Cartland. You're absolutely right. Fully understand the data, particularly in view of the Omicron variant. We will not be vaccinating our children because the harm's too much compared to the benefit gained from having the jab. And then the very next, day or two, they're sending children down to the vaccination clinic. It's just really odd.
We've been pretty doom and gloom, but do you see any place for the vaccination for people at any stage?
Not now. I think you got to remember what we're dealing with. I mean, in the current wave, and that's what I've had to be really careful to talk about. Omicron's very different. Like I can say that I saw the odd case sporadically of breathless, feverish people coughing their guts up at the very beginning. My own friend, by the way, died of COVID. So I'm not a COVID denier in any of this. So of course, there's a role for. And I'm not an anti-vaxxer. It's shaved off many deaths of all the worldwide diseases due to the childhood program, for example. So in terms of Omicron as an individual virus and a strain of virus, it's just not. I mean, I read the notes. My little study, I took the trouble to read all the notes, and mild flu-like illnesses at worst. Some didn't know they had anything. Some of them have an itchy nose or a bad head.
But we didn't start this due to or because of Omicron. We started this from the Alpha and the Delta variants. Now, vaccinating during a pandemic is totally also another discussion to be had. But was there a place then when the vaccines were first rolled out? Because you've mentioned for Omicron, not really, as there's no real benefit, but for the other variants, because I think that's a fair question, and I think that's a fair thing for people to ask and know.
No, it is a fair question. I mean, we're seeing even now, that even Pfizer, for example, the guy who runs Pfizer has come out and said that the vaccines actually are only efficacious, for example, for 4 months, 6 months. So there's never been any kind of commitment to looking at the innate humoral immune system, natural immunity in any of this. And likewise, I've never known a condition, a pandemic, where we've not received any sort of guidance on early treatment protocols. There's lots and lots of, early treatment that, stuff like budesonide, zinc, vitamin D, ivermectin. There are lots and lots of data that shows it's relatively cheap stuff, that's give a lot of benefit. Over and above vaccine, I know you've asked me specifically about the vaccine and was there a role at the beginning, but there's a role for a lot of things at the beginning. If somebody's got the start of a flu-like illness at the beginning of the pandemic, then tell them about zinc, cheap as chips, get it from the pound shop. Tell them about vitamin D and get that from the pound shop. Give them these things that are going to be immunosupportive before you even start talking about vaccines. But a lot of what's been happening through the whole pandemic is we've been chasing our tail, announcing a measure and then not exercising it. For example, you don't have to wear your masks anymore in 3 days. For example, if your masks are not necessary, then for example, at my own church, I can stand up and sing with a mask off. So as you sit back down, Omicron attacks from all angles, and these are the sort of illogical, weird things that we've been subject to, and it's been very well orchestrated in terms of a fear campaign, and very it's going to take some undoing, because people are literally, whether it's doctors, nurses, fellow humans that have had the jab. I think another interview called it buyer's remorse. It's people they've been complicit in this, and it's a very hard thing to unpick when you realise that that vaccination has caused the myocarditis. And interestingly, every single person who jabs, it goes in the medical notes, the individual who jabbed. So I wonder what the consequences of that would be in the future, particularly when the big companies have got immunity from prosecution when it comes to indemnifying any future harm claims till whenever it is in the far distant future. But every single individual vaccinator is named in the medical notes. So I don't know why that's been stipulated, but it's conspicuous, let's say.
That's interesting. I mean, the cognitive dissonance around what you're seeing, the effects of the vaccine and whatnot, it is mind-boggling. I think what I was getting at with asking you about the messaging is that fear campaign that was set out right at the beginning: wear your mask, stay home, stay safe, save your gran, and all the rest of it. But then that last bit about who vaccinated you and the indemnity for the big drug companies, the big manufacturers, is also an interesting thing, because the immigrants that have come over into the US, or migrants to the US, or asylum seekers, are exempt from vaccination. And the reason they're exempt from vaccination is because they don't fall under that specific country or the US's populace. So the vaccine companies don't have this immunity from prosecution. So they've said, right, we're not going to inject you because we don't have immunity. Now that seems a little bit iffy, to say the least, considering
everything's a little bit iffy, isn't it? Everything's inconsistent. I mean, there's never been a top-down approach to all of this. You got one country. I mean, even in the UK, look at this policy on vaccinating children. You know, Wales and Scotland are saying yay. UK, I don't think at the moment are saying yes. There's inconsistency within the United Kingdom. And then, you know, if you're from the outside looking in, these guys haven't got a consensus approach to anything from vaccinating to, you know, they couldn't agree with how long after the first jab that the second jab should be. That kept changing. The goalposts are changing ever daily, and it's so confusing to the doctors. So how the poor patient who just wants reassurance and to trust their medical practitioner, which is essentially that's the name of the game, isn't it? The worry is that the trust is going to be lost forever. You know, we've built our profession upon trust. And be an advocate of the patient, and you know, people trust you with their lives and their deepest secrets. When that's gone, when that trust is broken, then there's going to be some serious rebuilding required. And you know, I don't think these doctors can come back from it. Hence left.
With regards to the messaging, with the fear mongering, with the changing of the goalposts, there's I don't know if you're familiar with it, Biderman's chart of coercion. Are you familiar with that at all?
I've heard of it.
I could be wrong here, but I think it was prisoners of war from Vietnam, and then there was a psychologist who then developed this to see what the torture was, that was done there. And I'll read it as to the different points that they have with it, as it makes for some interesting reading when you compare what was done to us. So there's 1, 2, 3, 4, 5, 6, 7, 8 different steps. Isolation, stay at home, isolate. There's monopolization of perception, the messaging on the news, this fear, this continuous ticker tape. Anyone who spoke of a different viewpoint, whether it was early treatment, whether it was on mask mandates or the lab leak theory hypothesis, they were all removed. Humiliation and degradation. So those same groups, what you've mentioned already, doctors having to wear badges saying I'm unvaccinated or what have you. Exhaustion, weakening the mental and physical ability to resist by isolating people, by preventing how much activity you can do, closing down gyms, all the rest of it. Threats, the doctors who were told that they're going to lose their jobs. It happened to care workers, then it was going to happen to doctors. Occasional indulgences and people being allowed out for a brief period of time or not, you know, loosen the noose a little bit. And then demonstrating omnipotence. They knew exactly what the vaccines could and couldn't do. And then you've also got forcing a trivial demands, what you mentioned there with wear your mask while you're sitting down at church, but you can get up and you can take it off to sing, and then you have to put it back on again. Or when you're walking around in the restaurant, the mask has to be on. And then as soon as you sit down, there's all these different things that went with the messaging, that went with the fear, that you can pin onto that abusive, toxic relationship that we've had.
Beautiful. It's been beautifully orchestrated, really, when you think about it. It's somebody somewhere is very proud of themselves, whoever that person may be.
Are you familiar with SPI-B and SAGE at all?
Yeah, I spoke to UK Common about that actually. And you know, these are nudge units. This is work that we know is done behind the scenes, and you know, even to the wording of these things, they're all done with psychological backing. You know, the little treble, you know, you see treble word phrases, you know, like hands, face, space, bum, bum, bum. You know, it's all the same sort of rhythmic trebles of, you know, and there's proven psychological techniques, you know, and as you mentioned in that list, you know, it's been beautifully orchestrated, and it's confusing to everyone. You know, it's confusing. It's almost like a Stockholm syndrome now, because we've gone back to, you know, plan A. I still drive past people that are sat up in the car with their mask and visor on, alone, going around town where I live in Cornwall. They're walking around wary of each other, looking fearful, looking just concerning. It is, and they've got their chunky woolen, you know, face masks on that they don't need to wear, but they're so scared of disease and pathogens and things, that they're just gripped by that fear. And that's what is really important in all of this message, is that we have to acknowledge that fear. People have been subject to this for 2 years, so it's going to be hard to snap them out of this. And absolutely acknowledge the fact that, you know, scary times have ensued. You know, I've seen the same things, and I've been careful to say not only am I a doctor, but I'm also a dad and a human. And that sort of, you know, we're all subject to these signals. We're subject to that nudge, that spy bee, you know, propaganda that's flying about. That, you know, and that's the only thing I can think of that explains sort of dissonance amongst medical colleagues, nursing colleagues, churches, for example, where just everyone seems to just be shrugging everything off and not standing up for principles. Very odd.
As a medical professional, then, seeing what's occurred, seeing what's happened, what would be your advice to someone in order to recover from this? Because I don't want to pose the question of would you recommend the vaccine or not, as there's individual elements to be taken into account. But what would be your advice to someone in terms of getting over the psychological aspects here?
Just explore the alternative narrative. Really, we're talking about doctors or public or both. Or
Everyone.
Yeah. Just, I mean, everything's conspicuous in terms of like the censorship, for example. You know, when you speak out and you get shut down, that's a major red flag waving. You know, for somebody, if somebody's speaking out publicly and they get told to shut up or the police arrest them, for example, you kind of want to hear what they've got to say. So all I would say is open your ears. You know, listen to the alternatives. You know, there's lots of people out there now. There's lots of organisations that you know, are setting about putting the record straight on all of this, and just be true to what you're seeing. Because I mean, I don't think even just medical people. I think every member of the public knows somebody. There's always a story that somebody's got to tell of somebody that's become poorly after their vaccine. Somebody knows somebody that had a stroke the day after their jab, and just listen to these signals. And you know, I think the tide is turning because, for example, you know, our local paper down in Cornwall put something about get your 5 to 11 year not 5 to 11 year olds, 12 to 17 year olds down during half term. And the comment section from 2 weeks ago reads very differently to the comment section just this week, where people are telling them to put their vaccines where the sun doesn't shine, essentially. So people are waking up, and that's it. And the only way I can explain those people are, it's a bit like the people that are in that grey zone. Like, I've had 3 now, I'm not having any more. But that's where you need to explore that. And the way I've got around that is, you know, getting these people that are in that grey zone to look at the graphs. I don't want to kind of preach to them what the graphs show, let them talk. Some of the more successful ways I've got people to listen and wake up is that I've asked them to explain the graphs. You talk me through it, what do you say? These are not academic people, but they come to the same conclusions as me. And that's why we've got to be really careful. People have been scared out of their wits for 2 years now, and we've got to be sensitive to that. We can't just go browbeating them and, you know,
it's never going to work.
Never going to work. Got to meet them at the, and these are people who are like, you know, a guy just gave me a scale of people that are sort of 1 to 10 in this process now. So the 10 are the people who are, you know, receptive to all these things, are fully awake, to use their phrase. And you've got the 1s and the 2s and the 3s that, you know, even if they witness a murder and the fires, the gun being shot, they still wouldn't think that a murder had been committed. And then you've got the sort of grey zone in between, and they're the ones that are, I've had it myself, but I wouldn't vaccinate my kids. And then you have to explore that with them. Why? What have you seen? What have you heard? And explore that and gently walk with them, really. And that's what doctors do. And that's what concordance is with patients. You know, you give an opinion and you have to meet them halfway. It's therapeutic alliance, I think I called it earlier.
Yeah.
And we've got to remember that. These are scared people.
So you mentioned that you're working with the Heart Group now. And it's not that you're just sitting back after taking your garden leave and screw it, it's somebody else's problem. You're making steps towards doing something about it as well. You're not just talking about it, you're being about it. What is it you guys are trying to do with the Heart Group?
Just raise awareness, give that other narrative, the narrative that's shut down. I could easily have, just crawled under a rock after all this, but ultimately, the NHS is going to need rebuilding, and hopefully it's going to be rebuilt with people of integrity, people who are concerned about people's ethics. This is the future of the NHS, really, or whatever the next health service is going to be.
Okay, fantastic. Well, I think that's a nice positive note end things on. Have you got any last messages, anything that you think people should be paying more attention to?
No, I mean, all I would really say aside from that is that, I'll just appeal to my colleagues, the colleagues that do know. And I know because when I look them in the eye, you can tell that they know. That just if they're seeing things and hearing things, step forward. These people that are contacting me privately now, remember your oath. Remember the reason you took it. You became a nurse, a doctor, paramedic. Remember these things daily. Look yourself in the mirror every single day you go on duty. And I'm calling these people out in a way because we're talking about patient safety, which is the bread and butter of our profession. I'll just ask them to speak out, even anonymously. Mate, there's no good private messaging me on Facebook or Twitter. Talk about it, raise the alarm. I've answered with my job. I've had to cancel myself to be able to speak freely and unshackle myself, as it were. Just remember why you did the job that you're doing. And you've got to look your patients in the eye after all of this. When the dust settles, you've got to look your patients in the eye, and trust needs rebuilding. I'm calling them out, really.